Welcome, curious minds, to another deep dive.
Hello.
Have you ever wondered how doctors can hear so much about your health just by, listening to your heart?
Mm-hmm.
It's not magic, really. It's about deciphering the heart's secret language, those subtle sounds it makes.
Exactly.
Today, we're sort of becoming heart sound detectives. We're plunging into the intricate world of heart murmurs and the hidden stories they tell about our valvular health.
It's a fascinating area.
Our mission, really, is to take a stack of dense medical sources and pull out the crucial nuggets of knowledge.
Yeah, cut through the noise.
We're going to transform what can feel like overwhelming information into a clear, actionable understanding about how to distinguish and, well, truly grasp heart murmurs
Yeah.
and the conditions behind them. Think of it as your insider's playbook to these vital cardiac clues.
And that distinction is absolutely vital. Think of it like this. The heart produces these subtle clues in its sounds and through physical exam findings
Right.
that can reveal really significant underlying issues. So this deep dive, it's designed to be your shortcut, essentially, to understanding a critical area of cardiac health, helping you connect those subtle sounds to major diagnoses.
Okay, let's start unpacking this. We're using what we're calling the 5 golden rules for understanding heart murmurs.
Mm-hmm.
So first up, what is a murmur exactly?
Good starting point.
Fundamentally, it's an extra sound, often described as blowing or whooshing, right?
Mm-hmm. That's a common description. It signals abnormal blood flow through the heart valves. It's basically the sound of something not quite right in the flow pattern.
Like turbulent.
Exactly like turbulence. And that blowing or whooshing sound usually points to one of two main issues, either regurgitation or stenosis.
Okay.
A blowing sound typically signifies regurgitation. This means blood is flowing backward through a valve that hasn't closed completely, like a leaky door, really.
Gotcha. Leak.
Conditions like aortic regurgitation or mitral regurgitation fall into this category, and they often lead to what we call volume overload because blood keeps, sloshing back where it shouldn't.
Right. Inefficient.
Very. Now, that's different from stenosis. Stenosis is a narrowing or obstruction.
So the opposite problem almost.
In a way, yes. Think of stenosis as trying to push blood through a bottleneck. The valve just doesn't open wide enough.
Okay.
Both create abnormal sounds, murmurs, but they tell very different stories about what's going wrong mechanically.
So we've got blowing sounds for backward flow regurgitation and then obstruction for narrowing stenosis. Let's really unpack these golden rules to help navigate these sounds.
Okay, golden rule number 1, it's all about timing. Does the murmur happen during diastole or systole?
Right. The heart's rest and work phases.
Exactly. Diastolic murmurs occur when the heart is filling with blood its rest phase. These include aortic regurgitation, AR, pulmonic regurgitation, PR, mitral stenosis, MS, and tricuspid stenosis, TS.
Okay. AR, PR, MS, TS during rest.
A great mnemonic to remember this is ARMS rest, meaning these key ones, AR and MS, happen when the heart is resting and filling.
AR, MS rest.
Got it. In contrast, systolic murmurs happen when the heart is actively pumping blood out its work phase.
Makes sense.
And these involve aortic stenosis, AS, pulmonic stenosis, PS, mitral regurgitation, MR, and tricuspid regurgitation, TR.
AS, PS, MR, TR during work.
It's all about placing that sound within the cardiac cycle relative to the main heartbeats, S1 and S2.
Now, here's where it gets really interesting. The idea that you can change what you hear just by asking someone to, say, stand up or squat down.
Dynamic maneuvers.
That's golden rule number 2. Understanding how changes in blood flow back to the heart, what we call venous return or preload, can change a murmur's intensity. It's like finding a secret dimmer switch for these sounds.
It really is. And the general rule is pretty straightforward. When you increase venous return, like squatting, lifting the legs, or lying flat.
More blood coming back.
Exactly. It generally increases the intensity of all murmurs.
Right.
More blood flow means more turbulence, more sound.
Okay.
Conversely, decreasing venous return, like during a Valsalva maneuver, straining down.
Holding your breath and bearing down.
Right. Or simply standing up quickly, that generally decreases the intensity of most murmurs. Less blood, less noise.
But there are exceptions, right? That's where it gets tricky.
Ah, yes. The exceptions are crucial diagnostically. They behave completely opposite to the general rule.
Okay.
The murmur of hypertrophic cardiomyopathy, or HOCM, this is a condition where the heart muscle is thickened.
Right.
Its murmur actually gets louder with decreased venous return.
Why is that?
Because when less blood fills the heart, the thickened muscle walls come closer together, making the outflow obstruction worse. So less blood paradoxically makes that murmur louder.
Wow, okay. Counterintuitive.
It is. And the other big exception is mitral valve prolapse, or MVP. With MVP, decreasing venous return makes the heart cavity slightly smaller. This causes the characteristic click sound of MVP to happen earlier in the heartbeat cycle. And if there's an associated murmur of mitral regurgitation, its duration actually gets longer, even though the MR murmur itself might be fainter overall.
So the click is earlier, murmur lasts longer, with less blood returning.
Exactly. These exceptions, HOCM and MVP, are really key distinguishing features based on these maneuvers.
Okay, moving on. Our heart has 4 valves, mitral and aortic on the left, tricuspid and pulmonic on the right. How do we tell which side a murmur is coming from if they sometimes sound similar? That's golden rule 3, right?
Yes, and it's a common challenge. The answer often comes down to 2 things. Respiration, how breathing affects the sound, and the precise location where the murmur is loudest.
Okay, let's start with breathing.
So during inspiration, when you breathe in, more blood returns to the right side of the heart from the body. This naturally increases the intensity of right-sided murmurs, like pulmonic and tricuspid murmurs, makes them louder. At the same time, it slightly decreases the intensity of left-sided murmurs.
Okay, inspiration boosts the right side.
Then, during expiration, breathing out, more blood returns from the lungs to the left side of the heart.
Makes sense.
So that intensifies left-sided murmurs, aortic and mitral murmurs. In fact, left-sided murmurs are often best heard right after you breathe out completely. Hold it for a second.
Got it. Inspiration for right, expiration for left.
The second part of this rule is location of intensity. Murmurs are typically best heard where the turbulent blood flow is happening, not necessarily right over the anatomical valve location.
Ah, okay. Where the sound radiates to.
Kind of. So for aortic murmurs, AR or AS, you listen at the right upper sternal border, the RUSB, basically the upper right edge of the breastbone.
RUSB for aortic.
Pulmonic murmurs, PR or PS, are best heard opposite that, at the left upper sternal border, LUSB.
LUSB for pulmonic.
Then for mitral murmurs, MR or MS, you go down to the apex of the heart. That's usually around the left fifth intercostal space, mid-clavicular line, sort of under the left nipple area.
Apex for mitral.
And finally, tricuspid murmurs, TR or TS, are typically loudest at the left lower sternal border, near the bottom of the breastbone, sometimes called the subxiphoid area.
LSB for tricuspid. So location matters a lot.
A huge amount. Helps you pinpoint which valve is likely involved.
Okay, golden rule 4. Sometimes a murmur sound doesn't just stay put, it travels or radiates.
Exactly. This radiation pattern can be another vital clue.
Like where?
Well, mitral regurgitation, MR, very commonly radiates sideways, right into the left armpit, the axilla.
Okay, MR to the armpit.
And aortic stenosis, AS, and sometimes pulmonic stenosis, PS, can often radiate upwards into the carotid arteries in the neck. You can sometimes hear it if you listen over the neck.
ASPS up to the neck. Interesting. So the direction tells you something about the flow.
It tells you the direction of that turbulent jet of blood.
Okay, so beyond just general venous return changes, you mentioned specific maneuvers can really change murmur intensity, helping us fine-tune the diagnosis, almost like pushing different buttons.
Precisely. These are often called accentuation maneuvers. Let's look at a couple of key ones. Hand grip is a big one.
Clenching your fists hard.
Right. Clenching both fists tightly. This temporarily increases afterload.
Afterload. That's the resistance the heart pumps against.
Exactly. The resistance the left ventricle has to overcome to push blood out into the body. So hand grip makes it harder to pump blood forward.
Okay.
This maneuver tends to decrease the intensity of murmurs related to outflow, blood being pushed out of the heart. Think aortic stenosis and hypertrophic cardiomyopathy. The obstruction sounds become quieter because less blood is forcefully ejected.
Right, harder to get it out.
But hand grip increases regurgitant murmurs like aortic regurgitation and mitral regurgitation.
Why is that?
Because with more resistance to forward flow, more blood is forced backward through the leaky valve. So AR and MR get louder with hand grip. It also tends to increase mitral stenosis slightly.
Okay, hand grip. Less HOCM, more ARER.
You got it. Then there's amyl nitrate. This is a medication given via inhalation sometimes for testing that temporarily decreases afterload. It widens blood vessels.
So the opposite effect of hand grip.
Exactly the opposite. It makes it easier for the heart to pump blood forward.
So it should make AS louder.
Precisely. Amyl nitrate increases the intensity of aortic stenosis and hypertrophic cardiomyopathy murmurs. Easier forward flow makes the obstruction sound more prominent. It also increases the murmur of mitral valve prolapse,
Okay.
but it decreases regurgitant murmurs like aortic regurgitation and mitral regurgitation. Less resistance means more blood flows forward, so less leaks backward.
Makes sense.
And this principle is actually why medications that reduce afterload, like ACE inhibitors or ARBs, are often used therapeutically in managing chronic AR and MR. They help promote forward flow.
Fascinating how these simple maneuvers reveal so much. Okay, now that we have our golden rules, let's apply them. Let's dive into some specific valvular disorders, starting with the aortic valve. First up, aortic stenosis, AS.
Right, aortic stenosis. As we touched on, it's like having a stubborn, narrow gate on the heart's main exit, the aortic valve, from the left ventricle.
The main pump chamber.
Yes. When that gate is stuck partially closed, the heart struggles to push blood out to the body. This leads to what we call a fixed cardiac output. The heart can only pump so much blood no matter how hard it tries, especially during exertion.
Like trying to force water through a tiny pipe.
Perfect analogy. This constant struggle makes the heart muscle thicken, that's left ventricular hypertrophy, or LVH, as it tries to compensate. But eventually, the muscle can get exhausted and fail.
And this is common.
It's actually the most common valvular disease, particularly in older adults. It becomes clinically critical when that valve opening narrows significantly, typically to less than 1 square centimeter. Normal is maybe 3 to 4 square centimeters.
So what causes AS? Is it just aging?
That's a great question. The cause often depends on the age. In folks over 70, it's usually degenerative calcification, just wear and tear. The valve gets stiff and chalky over decades. But if you see significant AS in someone younger, say under 70, you start thinking about other causes. A big one is a congenital bicuspid valve.
Born with it.
Born with an aortic valve that has only 2 leaflets instead of the usual 3. It works okay for a while, but it wears out faster, leading to stenosis earlier in life. Rheumatic heart disease can also cause it, though less commonly now for AS in many places.
And what symptoms would someone experience? What's the outlook if they have symptoms?
This is critical. Aortic stenosis can be asymptomatic for a long time, but once symptoms develop, the prognosis changes dramatically without intervention. The classic triad is exertional dyspnea, shortness of breath with activity, that's the most common angina, or chest pain, and syncope, fainting spells.
So symptoms are a serious sign.
A very serious sign. Once symptomatic, survival rates drop significantly without valve replacement.
And if we were listening, what would we hear or feel?
You'd expect that harsh, often low-pitched, mid to late peaking systolic crescendo decrescendo murmur gets louder than quieter. Best heard at the RUSB, that right upper sternal border.
And it radiates.
Often radiates up to the carotid arteries in the neck. You might also feel a weak, delayed carotid pulse, the pulsus parvus et tardus we mentioned.
Small and slow pulse.
Right. And possibly a fourth heart sound, an S4, which is due to that stiff, hypertrophied left ventricle struggling to receive blood.
How do doctors confirm it for sure?
Echocardiogram is the test of choice. It's an ultrasound of the heart. It shows the thickened LV wall, assesses the valve area directly, sees how calcified it is, and measures the pressure gradient across the valve.
And the treatment. You mentioned valve replacement.
Yes, for symptomatic severe AS, surgical aortic valve replacement, AVR, is really the only effective treatment. Newer, less invasive techniques like TAVR, transcatheter AVR, are also common now, especially for older or higher risk patients. Medical therapy alone doesn't fix the valve. It mainly manages symptoms or treats coexisting conditions. And you actually want to avoid things that dramatically lower blood pressure or reduce preload, as the heart can't compensate well with that fixed output.
Got it. Okay, let's switch gears to aortic regurgitation, AR. The opposite problem, you said.
Pretty much. AR is about incomplete closure of the aortic valve. So during diastole, when the left ventricle is supposed to be relaxing and filling from the atrium,
Right.
blood leaks backward from the aorta into the LV. This causes LV volume overload, it gets too much blood leading to dilation, the chamber stretching out like an overfilled balloon, and eventually hypertrophy as it tries to handle the extra volume.
How does someone get AR? Is it always a slow leak?
Good question. It can be chronic, developing slowly over years or decades. Common causes include that bicuspid aortic valve again, rheumatic heart disease, long-standing hypertension, connective tissue diseases like Marfan syndrome.
Okay.
But it can also be acute severe AR. This is a medical emergency.
What causes that?
Often things like infective endocarditis destroying the valve cusp, or an aortic dissection, a tear in the aorta's wall extending down to the valve. Acute severe AR happens suddenly. The heart has no time to adapt, and it can rapidly lead to pulmonary edema fluid backing up in the lungs and cardiogenic shock. Very dangerous.
So what are the telltale sounds for AR?
The classic murmur is high-pitched, blowing, and decrescendo. It starts loud right after the second heart sound, S2, and fades away during diastole.
And where do you listen?
Best heard along the left sternal border, often specifically at a spot called Erb's Point, which is the third left intercostal space.
No.
Sometimes louder if the patient leans forward and holds their breath in expiration.
Now, I've heard there are some really distinctive, almost dramatic physical signs associated with chronic severe AR. Is that right?
Oh, absolutely. They're quite famous. These peripheral signs reflect the wide pulse pressure, the large difference between systolic and diastolic pressure caused by that large volume of blood being ejected and then leaking back.
Like,
Well, there's the Waterhammer pulse, or Corrigan's pulse, a very rapid bounding upstroke of the pulse that collapses just as quickly. You feel it best in the radial or carotid artery.
okay.
Hill's sign is when the systolic blood pressure in the leg, popliteal, is significantly higher, maybe 60 millHg or more, than in the arm, brachial.
Wow.
De Rosier's sign is hearing both systolic and diastolic bruits, or murmurs, when you lightly press the stethoscope over the femoral artery. Traub's sound, or pistol shot femorals, is a sharp sound heard over the femoral artery with each heartbeat.
Pistol shots, seriously.
Seriously. And then there are visual signs. De Musset's sign, which is that subtle head bobbing in time with the heartbeat. Miller's sign, visible systolic pulsations of the uvula. Quinch's pulses, visible pulsations in the fingernail beds when you press lightly on them.
That's an incredible list. It really shows how systemic the effects are.
It really does. You might also hear an Austin Flint murmur, which is a separate, low-pitched, mid-late diastolic rumble heard at the apex. It's thought to be caused by the regurgitant jet hitting the mitral valve leaflet.
How is AR managed then?
For chronic AR, medical therapy focuses on afterload reduction, using drugs like ACE inhibitors, ARBs, or nifedipine to reduce the resistance the heart pumps against, promoting forward flow and reducing the leak.
Makes sense.
But ultimately, surgical intervention valve repair or replacement is definitive, especially once symptoms develop, the left ventricle starts significantly dilating or its pumping function declines. And of course, acute severe AR requires urgent surgery.
Okay, let's move across the heart to the mitral valve. Mitral stenosis, or MS.
Right. Mitral stenosis, MS, is almost always caused by rheumatic heart disease.
From strep throat way back when.
Exactly. Inflammation from rheumatic fever can cause scarring and fusion of the mitral valve leaflets over many years, narrowing the valve opening between the left atrium and left ventricle.
So another bottleneck.
Another bottleneck, this time blocking flow into the main pumping chamber. This causes pressure to build up behind the valve in the left atrium.
And that backs up into
the lungs. Increased left atrial pressure leads to pulmonary venous congestion and often pulmonary hypertension, high blood pressure in the lung arteries.
So the symptoms are mainly respiratory, though.
Yes, pulmonary symptoms are very common due to that backup. Exertional dyspnea, shortness of breath with activity, is usually the first and most common symptom. Also, exercise intolerance, cough, sometimes hemoptysis, coughing up blood.
And complications.
Atrial fibrillation is a very frequent complication because the left atrium gets enlarged and stretched, which disrupts its electrical activity. AFib in MS significantly increases the risk of stroke from blood clots forming in the stagnant blood within the enlarged atrium.
Anything else visually?
Sometimes you might see mitral facies, rosy, flushed cheeks with a bluish tinge due to chronic low oxygen and vasodilation, or even Ortner's syndrome, hoarseness, caused by the enlarged left atrium compressing the recurrent laryngeal nerve against the pulmonary artery.
Wow. And what does MS sound like?
It has a pretty distinctive set of sounds. You often hear a prominent, loud first heart sound, S1. Then, after the second heart sound, S2, there's an opening snap, OS.
A snap.
Yes, a high-pitched snapping sound as the stiff, doming mitral valve is forced open by the high atrial pressure. This OS is then followed by the characteristic murmur, a mid-diastolic rumbling murmur, low-pitched, best heard at the apex.
Rumbling. Like distant thunder.
That's a classic description.
Yeah.
And it's often best heard with the bell of the stethoscope with the patient lying on their left side after exhaling fully.
Anything else about the timing?
Yes, the timing of the opening snap is important. The interval between S2 and the OS gets shorter as the stenosis becomes more severe. A shorter S2-OS interval means higher left atrial pressure forcing the valve open earlier.
And the treatment for MS?
Percutaneous balloon valvuloplasty is often the preferred treatment, especially for younger patients whose valves aren't heavily calcified or leaky.
How does that work?
A catheter with a balloon is threaded up to the mitral valve, and the balloon is inflated to stretch the narrowed opening. It can be very effective. If that's not suitable, then surgical options like commissurotomy, cutting the Fee's leaflets, or valve replacement are considered. Managing AFib and preventing clots with anticoagulants is also crucial.
Okay, now let's talk about the other main mitral problem, mitral regurgitation, or MER.
Right. In MER, the mitral valve doesn't close completely during systole when the left ventricle is pumping.
So blood leaks backward again.
Exactly. Blood flows backward from the high-pressure left ventricle into the lower-pressure left atrium during systole. This causes LV volume overload because it has to handle both the normal inflow plus the regurgitated blood, and eventually it leads to LV dilation and hypertrophy. It also increases pressure in the left atrium and potentially backs up into the lungs.
What causes MER? Is it rheumatic fever again?
Rheumatic fever can cause it, but in developed countries like the US, the most common cause of chronic MR is actually mitral valve prolapse, MVP, which we'll discuss next.
Okay.
Other causes include damage from infective endocarditis or dysfunction of the papillary muscles or chordae tendineae, the heartstrings holding the valve, often due to a heart attack or ischemia. Degenerative changes with age can also cause it.
And symptoms.
Chronic MR can be asymptomatic for years, even decades. When symptoms develop, they're often related to heart failure, exertional dyspnea, fatigue, orthopnea, trouble breathing lying flat. Acute MR, say from a ruptured papillary muscle after heart attack, is a surgical emergency, often causing sudden severe pulmonary edema and cardiogenic shock.
What's the distinctive sound of MER?
It's typically a high-pitched, blowing, holosystolic murmur.
Holosystolic meaning?
It lasts throughout the entire systolic period, from S1 all the way to S2, often obscuring both sounds. It's usually loudest at the apex.
And does it radiate?
Yes. Classic radiation is to the left axilla, the armpit. That's a key feature differentiating it from, say, aortic stenosis radiating to the neck.
How is MER managed?
Medical therapy often involves afterload reducers, like ACE inhibitors or ARBs, especially if the patient also has hypertension. These help promote forward flow. Diuretics can help manage volume overload symptoms.
Sometimes surgery.
Surgical intervention is indicated for symptomatic severe MR or even in asymptomatic patients if there's evidence of significant LV dilation or dysfunction. Valve repair is generally preferred over replacement whenever feasible, as it preserves more of the natural valve structure and often leads to better long-term outcomes.
Okay, you mentioned mitral valve prolapse. MVP is the most common cause of mitral failure. Let's dive into that specifically.
Right, MVP. This is a condition where one or both mitral valve leaflets actually bulge or prolapse backward into the left atrium during systole.
Like they're too floppy.
Essentially, yes. It's often due to something called a myxomatous degeneration, where the valve tissue itself is abnormally stretchy and elongated, along with the chordae tendineae. It's actually very common, found in maybe 2–3% of the population, and while many people with MVP have some degree of MR, it's often mild.
What are the clinical signs? Is everyone with MVP symptomatic?
No, most patients are completely asymptomatic and it's found incidentally. However, some people experience a collection of symptoms sometimes called MVP syndrome.
What does that involve?
Things like atypical chest pain, not classic angina, palpitations, shortness of breath, dyspnea, dizziness, fatigue, anxiety, panic attacks. It's thought that some of these symptoms might relate to autonomic nervous system dysfunction rather than the valve prolapse itself.
Okay. What's the unique physical exam finding for MVP?
The classic auscultatory finding is a mid-late systolic click.
A click.
Yes, a sharp, high-pitched clicking sound heard somewhere in the middle or latter part of systole, usually at the apex. It's thought to be caused by the sudden tensing of the elongated chordae tendineae as the leaflet prolapses to its limit.
Is there always a murmur too?
Not always, but the click may be followed by a mid to late systolic murmur if there's accompanying mitral regurgitation. Now, what's really fascinating and diagnostically useful here is how maneuvers affect the timing of the click and the duration of the murmur.
This goes back to the venous return changes.
Exactly. Remember how decreasing preload, like standing up or Valsalva, makes the LV smaller?
Right.
In MVP, a smaller LV volume causes the prolapse to happen sooner in systole, so the click moves earlier, closer to S1. And because the prolapse starts earlier and lasts longer, the duration of the associated MR murmur becomes longer.
So stand up,
Yeah.
earlier click, longer murmur.
Precisely. Conversely, maneuvers that increase preload, like squatting, leg raise, or even hand grip, which increases LV size slightly, make the LV larger. This delays the onset of prolapse.
So the click is later.
The click moves later in systole, closer to S2, and the duration of the murmur becomes shorter. This dynamic change in timing with maneuvers is really characteristic of MVP.
That's a very neat diagnostic trick. And the management for MVP, is it serious?
For most asymptomatic patients with no significant MR, it's generally considered benign. The main thing is reassurance and periodic monitoring with echocardiograms if there's any MR present.
What if they have those MVP syndrome symptoms?
If patients are bothered by palpitations or autonomic symptoms, beta blockers won't be used. Otherwise, management focuses on addressing any significant MR if it develops, following the guidelines for MR treatment, including potential surgery if it becomes severe. Endocarditis prophylaxis, antibiotics before dental procedures, used to be recommended, but generally isn't anymore unless they have had endocarditis before or have prosthetic material.
Okay, that covers the main left-sided valve issues. What about the right side? Tricuspid and pulmonic valves. Are they as common?
Generally, significant disease of the right-sided valves is less common than the left, but let's briefly touch on them. Pulmonic regurgitation, PR, a leaky pulmonic valve, is often found incidentally and is usually clinically insignificant unless severe.
What does it sound like?
If audible, it's usually a high-pitched, blowing, early diastolic murmur heard best at the left upper sternal border, LUSB. Sometimes, if it's due to pulmonary hypertension, it's called a Graham-Steele murmur.
Okay. And tricuspid stenosis.
Tricuspid stenosis, TS, is quite rare, almost always rheumatic in origin, and often occurs alongside mitral stenosis. It obstructs flow from the right atrium to the right ventricle.
So symptoms of right heart failure.
Exactly. Blood backs up into the right atrium and then into the systemic veins, leading to things like jugular venous distension, enlarged liver, ascites, fluid in the abdomen, and leg edema. The murmur is a mid-diastolic rumble similar to MS, but heard best at the left lower sternal border, LLSB, and it typically intensifies with inspiration.
And tricuspid regurgitation.
Tricuspid regurgitation, TR, is much more common than TS. It's often functional, meaning the valve itself is okay, but the right ventricle has dilated, often due to left heart failure, lung disease, or pulmonary hypertension, stretching the valve ring so the leaflets don't meet.
So leaky again.
Leaky again. Backward flow into the right atrium during systole. Again, you see signs of right-sided heart failure. The murmur is a high-pitched holosystolic blowing murmur, best heard at the subxiphoid area, or LLSB.
Anything special about the TR murmur?
Yes. The key distinguishing feature is Carvalho's sign. The intensity of the TR murmur characteristically increases with inspiration.
Why is that?
Remember how inspiration increases venous return to the right heart? More blood flowing across the leaky tricuspid valve during systole makes the murmur louder. This helps distinguish TR from MR, as MR, being left-sided, usually doesn't increase or might even decrease with inspiration.
Carvalho's sign for TR. Got it. Okay, that's a lot of information.
It is.
So what does this all mean for us? Let's try to bring it all together, maybe highlight the key ways these conditions differ, just to make it easier to grasp the nuances, like a quick comparison.
Absolutely. Let's consolidate. Thinking comparatively is key.
Okay, so timing first, systolic versus diastolic.
Right. Systolic crew. Aortic stenosis, AS, mitral regurgitation, MR, mitral valve prolapse, MVP, click murmur, tricuspid regurgitation, TR, pulmonic stenosis, PS. They happen when the heart is pumping out.
And diastolic.
Diastolic crew, aortic regurgitation, AR, mitral stenosis, MS, tricuspid stenosis, TS, pulmonic regurgitation, PR. They happen when the heart is filling or resting. Remember, AR, MS, rest.
Good. Now sound quality and radiation.
Big differences here. AS, harsh, crescendo decrescendo, radiates to carotids. AR, high-pitched, blowing decrescendo down the left sternal border. MS, low-pitched, rumbling mid-diastolic at the apex, often with an opening snap. Mr. High-pitched, blowing holosystolic apex, radiates to axilla. MVP, mid-late systolic click, maybe the late systolic murmur. TR, blowing holosystolic, LLSB, louder with inspiration.
Okay, that helps differentiate the what and where. Now, the impact of maneuvers. This seemed really key.
Super key. Let's focus on hand grip and maybe amyl nitrate or Valsalva squatting. Hand grip increases afterload, decreases AS and HOCM, increases AR, MR, and VSD murmurs.
Opposite effects.
Right. Amyl nitrate decreases afterload, increases AS, HOCM, MVP, decreases AR.
And venous return changes.
Yep.
Squatting versus standing Valsalva.
Increased venous return, squatting leg raise, makes most murmurs louder, exceptions. HOCM murmur gets quieter, MVP click is later, murmur shorter.
Decreased venous return, standing Valsalva. makes most murmurs quieter. Exceptions. HOCM murmur gets louder, MVP click is earlier, murmur longer.
Those HOCM MVP exceptions are classic.
What about accompanying signs?
Think beyond the murmur. AS weak delayed pulse, parvis et tardus, S4, chronic AR wide pulse pressure, bounding pulses, water hammer, those numerous peripheral signs. M loud S1, opening snap, AFib common, MVP of the click, TR Carvalis signs of right heart failure.
And primary etiology, the common causes.
Quick recap. MS almost always rheumatic, MR often MVP or ischemic degenerative, S often calcified degenerative, older or bicuspid, younger, TR often functional due to RV dilation.
And finally, the core pathophysiology.
Stenosis, obstruction to forward flow, ASMS, PSTS. Regurgitation, backward leaky flow through an incompletely closed valve, AR, MR, PR, TR. MVP is floppy leaflets leading to regurgitation.
Okay, that comparative framework really helps pull it together.
Hopefully. It's about layering these different clues, timing, sound, location, maneuvers, other signs, to build a diagnosis.
We've just taken quite a deep dive into the fascinating world of heart murmurs and valvular disorders. It really is amazing how much information our bodies can reveal through sound and these simple maneuvers. It feels like unlocking a hidden language.
Indeed. And understanding these golden rules, these specific characteristics, it really allows for a more rapid, insightful assessment in a clinical setting. It helps turn seemingly subtle sounds into clearer diagnostic clues. It's about listening deeply, to the body's symphony, or sometimes its dysfunctions.
Thank you so much for walking us through all of that. This has been incredibly illuminating, and thank you for joining us on this deep dive.
My pleasure. We hope this exploration has given you, the listener, a clearer understanding of these critical cardiovascular conditions.
And maybe just for your own reflection as we close, how might really understanding the mechanics of blood flow, visualizing that flow, help you appreciate the effects of these murmurs? And maybe appreciate the intricate dynamic symphony of the human heart even more. We'd encourage you to perhaps listen more closely to the sounds around you, even outside of cardiology, and just consider what hidden information they might hold.